Students at Keynote Speaker Global Authority. I'm passing the mic on to you, Madhuri.
Hey guys, I'm Madhuri.
So they're just doing some intros.
I'm passing the mic on to you, Madhuri.
Passing the mic to Billy. Hey guys, I'm Madhuri.
My name is Billy Wilkerson. I'm an undergraduate at Dickinson College. I'm really excited for the show tonight. Passing the mic on to Lexi.
Hi everyone, my name is Lexi Van de Kieft and I'm an aspiring healthcare professional and really looking forward to our speakers tonight. So I'm passing the mic on to
Hello everyone, I'm Asma and I'm a medical student from India. Passing on the mic to Ben.
Hi everyone, I'm Gayatri Prabhumenan. I'm a fourth year medical student from TSMU Jamshedpur. I'm so excited to be here. Passing the mic to you, John.
Okay, I see that Lauren has joined us, so that means that our speaker is ready, and I will be handing the mic to Lauren. So as we move to the keynote lecture portion, the YouTube live stream link will be posted above, and you can see Dr. Mesa's presentation in real time. If you have questions regarding today's talk, you can back channel to our wonderful moderators on stage, to Madhuri, Billy, Lexi, Asta, and Gayatri, and we will actually have your questions on the queue. We will be turning off the hand raising during the lecture portion, and if you are a known contributor to the conference moderators, please back channel us or our moderators, and you will be invited on the stage to ask your question. Now I pass the mic on to Lauren.
Thank you so much. Hello, everyone, and thank you so much for joining us for the MedNews Week conference. Our goal here on this platform is to bring you the most cutting-edge medical information from leading physicians and researchers in their fields. My name is Lauren Vento, and I will be your host today. Just a quick note on our two founders and co-hosts, Dr. Jan Leifman, who is a renowned cancer researcher, and Dr. Chandler Park, who is president of Kentucky ASCO and has published over 100 peer-reviewed papers, including in the Nccn, and he is also the host of the nationally televised Master's Lecture Series. We are fortunate to have a great team to make these events a reality. Our chairs include Dr. Chandler Park, president of Kentucky ASCO, Dr. Yvuz Saleh, and Dr. Leifman. Our organizing committee is composed of myself, Alexandra Vandekuyt, and Pratusha Ganta. Our educational committee includes Sean Jakowitz, Amaral Chamoun, Pallavi Pai, and Melissa Mana. The managers of MedNews Week are Alexandra Vandekuyt and Pratusha Ganta. The associate managers are Muskan Joshi, Billy Wilkerson, and Gayatri Menon. Our director of video production is Sean Jakowitz. Our media director is Pallavi Pai, and the moderator for today's event will be Pratusha Ganda. Okay, now on to our speaker today, Dr. Ruben Mesa. He is currently the executive director of Mays Cancer Center at UT Health San Antonio, MD Anderson. He is a global authority on myeloproliferative neoplasms and experimental therapeutics, and he led the development of the first U.S. National Comprehensive Cancer Network's panel guidelines for the diagnosis and treatment of myelofibrosis, polycythemia vera, and essential thrombocythemia. He is committed to advancing cancer health equity, both personally as a Latino Cancer Center director and professionally as a central mission of Mays Cancer Center is advancing the science of cancer in Latinx patients. He was a co-leader who contributed to the FDA approval of ruxolitinib and fedratinib, and he has been involved in MPN research for over 20 years and has directed over 100 clinical trials internationally. Currently, he leads the NCI P01 funded MPN Research Consortium and is a member of the NCI Clinical Trial Advisory Committee. He has authored more than 400 peer-reviewed manuscripts, 452 abstracts, 14 book chapters, 102 web publications, and more than 43 editorials in the field of myeloproliferative neoplasms. These include journals such as the New England Journal of Medicine, Lancet, the Journal of Clinical Oncology, and JAMA Oncology. Dr. Mesa is an editorial board member of many national and international journals, including Hem-Onc Today, American Journal of Hematology Oncology, European Medical Journal Hematology, and Cambridge Research Center. He is also a peer reviewer for many well-known journals, including the Lancet, British Medical Journal, and the New England Journal of Medicine. He actively participates in many organizations, including the board of the Leukemia and Lymphoma Society. He is the chief medical advisor of the MPN Advocacy and Education International, and on the board of directors for the MPN Education Foundation. He's also a member of the Mayo Clinic Research Committee and the MD Anderson Moonshot Program and Review Panel. He has been recognized as one of Texas's top doctors in 2020, one of the best San Antonio doctors also in 2020. He received the Cancer Care Physician of the Year Award in 2015. He was named as a top oncologist in Scottsdale, Arizona in 2014, and one of Phoenix Super Doctors in Arizona magazine. He's the recipient of the Career Award, MPN Translational Research. He also was the recipient of the MPN Advocacy and Education Career Recognition Award. He was named with the Top Faculty Award in Mayo Clinic from 2011 to 2014, and the Mayo Clinic Investigator of the Year Award in 2013. Dr. Mesa received his MD from the Mayo Clinic College of Medicine, and he completed his residency in internal medicine and his fellowship in hematology and medical oncology at Mayo Clinic as well. He stayed on at Mayo Clinic and eventually was named the chair of hematology and medical oncology for the Mayo Clinic on their Arizona campus from 2009 to 2017, where he oversaw hematology, medical oncology, and stem cell transplant and palliative medicine. Additionally, Dr. Mesa was deputy director of the Mayo Clinic Comprehensive Cancer Center and helped oversee all efforts related to cancer practice, education, and research in Arizona and the development of cancer service line across Mayo Clinic. During his tenure at the Mayo Clinic, Arizona, it progressed from an unranked to be one of the top 20 US News and World Report rated cancer hospitals in the USA. In 2017, Dr. Mesa was recruited to join UT Health San Antonio as executive director of the Cancer Center, where he is currently. Under his leadership, this cancer center was named as a partner site of the MD Anderson Partner Cancer Network. So without any further ado, Dr. Mesa, welcome to our stage, and we are very happy to have you.
Well, great. Well, thank you, Lauren, and really way too generous an introduction. I think even my mother would have blushed at that one, but thank you very much. Well, excited to join today. You know, looking both at the website as well as kind of the spirit and content of this effort. Yeah, I'm excited to contribute and to join. You know, some wonderful colleagues that have preceded me. Saw that my good friend Rami Kamraji similarly gave a recent talk on the latest updates for patients with myelodysplastic syndrome. So really excited to be here. And my hope is really to bring people really right up to the moment in terms of where we are with the therapy of MPNs. Indeed, just having traveled back from the ASCO meeting and the European Hematology Association meeting, which ended about a week ago, try to bring you the very latest data as it relates to the therapy of these disorders. These are my disclosures. So first, as we talk about myeloproliferative neoplasms, let's talk a little bit about the goals in these diseases as well as the targets. So the myeloproliferative neoplasms, we're going to speak really today about 3 diseases that are interrelated. They're chronic leukemias. They include essential thrombocythemia, polycythemia vera, and myelofibrosis. And these in aggregate represent about roughly 450,000 patients in the US. I like to tell individuals they're not common diseases, but nor are they rare. You know, they're not an atypical HUS or other diseases that really are quite uncommon. There are plenty of patients out there that unfortunately labor against these diseases. Indeed, I was at clinic today and saw 10 new patients with MPNs just today alone, ranging today from a 15-year-old with ET to a 91-year-old with polycythemia vera. Now, given they're a very heterogeneous group of diseases, we've given a lot of thought to try to understand, you know, how are the patients afflicted? And indeed, there's a range of ways that they burden the patient that faces them. One, they can have risk of vascular events. They can have risk of thrombosis or bleeding. That's more common in P. vera and ET, but it can happen in myelofibrosis. They can have risk of cytopenias, with anemia being much more common in patients with myelofibrosis. They can have splenomegaly that is predominant in myelofibrosis, but it can be present in ET or PV. They can have difficult disease-associated symptoms in all three of the diseases. We believe these symptoms are tied to the biology of the disease. And they can have risk of progression from early MPN, PV, or ET into myelofibrosis. They can go from myelofibrosis to AML. Indeed, as I visit with patients, as I had this discussion with them today, for most individuals who are diagnosed with an MPN, it is progression which is the greatest risk. Because for most individuals, if they are managed, they would live out their normal lifespan if the disease did not progress. Now, all of these things occur in the setting of a person that brings to the table their age, their comorbidities, their level of fitness, and their own individual wishes and desires as it relates to their healthcare and goals in life. Now, let's begin with discussing both the current therapy as well as evolving new options for the earlier MPNs, ET and PV. These are the most common of the MPNs. In aggregate, this represents probably 300 to 400,000 individuals in the United States. Now, the incidence is not super high, new patients per year, but the prevalence is quite a bit higher as a reflection that many of these individuals, fortunately, will live out their normal lifespan. ET in aggregate does shorten the lifespan as an aggregate whole, but modestly so. With polycythemia vera, it is more definitive. So let's first start with ET. Now, I bring up a couple slides from the NCCN treatment guidelines. Indeed, I partnered with other colleagues to try to bring some uniformity to how we address MPNs in the United States by creating these guidelines. I think NCCN provides a great service. It provides some great, I think, consistency and uniformity of approach across a US practice, particularly with diseases like this. So with ET, one, we primarily, let's start with high risk, because this is the group that we primarily utilize medical therapy. There's a few key things I would point out here. So one, these are individuals with high platelets. They have risk of thrombosis or bleeding. Maybe they've already had thrombosis or bleeding. We want to first manage cardiovascular risk factors. We consider low-dose aspirin. There's some data on low-dose aspirin twice a day. And our initial preferred regimens to try to normalize the platelet count under 400,000, control leukocytosis if present, is either hydroxyurea or long-acting interferon, such as pegylated interferon. Finally, anagrelide can be considered. In my own practice, I find anagrelide is a helpful therapy, but usually in combination with a second therapy. There are not many patients that tolerate high-dose anagrelide. Then as you're treating them, you're aiming to get the counts under control. And you're monitoring for many things. Are they tolerating the medicine well? Are they not having vascular events? Are the counts in the goal range that you have? If so, continue. If not, we consider a second-line therapy or both in an investigator-initiated study, which is at my center, as well as a broader international study. Here, with these individuals, this medicine is impacting inflammatory cytokines and impacting growth factors. Now, in data from this year's American Society of Hematology meeting in December in Atlanta, we saw that the data from the phase 2 study was presented. This in a European study, this showing aggregate data, but showing a very nice decreased control in the platelet count in individuals that had failed one or more lines of therapy, including hydroxyurea. And this showed, again, almost universal response again across these individuals. Similarly, we've had good results in our investigator-initiated study in San Antonio. Next agent I would highlight, so backing up just a bit. So these data are leading to a phase 3 global study that'll be opening up soon for bomedemstat in patients with ET. There is an ongoing global phase 3 study in ET. This is with rho-pegylated interferon alpha 2b. We're going to discuss this agent in the context of polycythemia vera, where it has recently been approved. Dr. Serge Verstavchik and I, Serge Verstavchik from MD Anderson in Houston, are leading this global study for second-line therapy in patients with ET with leukocytosis, rho-pegylated interferon alpha 2b versus anagrelide. So this is continuing to accrue, but if you have patients that sound that they fall into that category, please consider referral to one of the sites. Polycythemia vera is very similar to ET in many ways, but one critical way that it is different includes the presence of erythrocytosis. So again, we manage cardiovascular risk factors. And I'd say do so aggressively. There have been studies that have been done that if you were to take an MPN patient with cardiovascular disease and they see a cardiologist, the cardiologist really controls the cardiovascular risk factors and is not overly mindful of the blood counts. You flip it around, if they see a hematologist, we control their blood counts, but we're not very picky about their cholesterol. Truly, both things need to be controlled. Diabetes, smoking cessation, aggressive control of hypercholesterolemia, exercise, diet, these things are important. Aspirin, of course, just like the discussion in ET, and there's randomized data showing the benefit of low-dose aspirin in these individuals. Now, a critical additional step is the control of hematocrit, to maintain a hematocrit under 45%. Now, in the past, this was a bit lax. People would come in, their hematocrit was 48, you'd say, well, we'll check it again in a month. We now recognize from randomized studies that controlling the hematocrit under 45, having 45 as a ceiling, is important. There was a study done in Italy that hematocrits of 45 to 50 were associated with significantly higher rates of thrombosis. So if it's 45.1, do a phlebotomy. If it's hanging around 45, they probably need tighter control of disease with either better cytoreductive therapy, higher dose, or another approach. Now, in high-risk disease, we use frontline therapy, and you'll notice that the frontline therapy is the same as the frontline therapy we consider in ET, hydroxyurea or pegylated interferon. And as we're monitoring the disease, we're monitoring it in a very similar way. ET and PV are very much kissing cousins of one another, with the hematocrit really being the significant difference. Now, as they start on cytoreduction, it's critical to see, well, did you achieve your goal? So things that would lead you to consider second-line therapy is one, obviously, if you don't achieve your goal with the first-line therapy. It's not uncommon to have someone on hydroxyurea, but on a dose that is insufficient to adequately control their counts. You got to control their counts. Are they not having thrombosis or bleeding? Are they needing ongoing phlebotomy? Do they have splenomegaly? Are the counts going up, or do they have difficult to control symptoms? If the answer to any of these is yes, then we need to consider a change. Is that a higher dose of medication or a different medication? Now, unlike in ET, there is an FDA-approved therapy in the second-line setting for P-vera, specifically ruxolitinib. So we'll get around to discussing that in myelofibrosis, but it is a clear therapy in the second line for P-vera. Additionally, if you had started with hydrea or interferon, one can consider switching to one of the other two. But my preference, if I'm going to second line, is probably to go to ruxolitinib, as it has the greatest data in this second line setting. Now, there is a new interferon that has become on the market for US patients and now globally, rho-pegylated interferon alpha 2b. These are data straight from the EHA meeting just a few days ago, showing long-term results from the definitive study that led to the approval of the rho-pegylated interferon. They followed for a long period of time patients with rho-peg versus hydroxyurea, and then a continuation study that included crossover. What they showed over time was significant superiority for both complete hematologic response as well as molecular response for rho-pegylated interferon alpha versus the control group. And why this matters is molecular response may well be associated with event-free survival, and complete hematologic response associated with improvement in risk of thrombosis or bleeding and symptomatic improvement. This showing here, again, clear superiority as it relates to hematocrit control well into, deep into the study, 4 or 5 years in, showing better durable control. Additionally, a very significant difference as it related to the percentage of patients that achieved a JAK2 allele burden less than 1%. So we believe a deep level of control. Now, on this slide that I think was one of the most interesting slides from EHA 2022 as it related to MPNs, was showing the event-free survival of individuals that went on rho-peg versus the control arm. And this is highly significant. This is risk of death, disease progression, and thromboembolic events. Again, showing even though in our NCCN guidelines we had hydroxyurea and interferon as interchangeable options, this increasingly showing the attractiveness of rho-pegylated interferon for these individuals. Now, it was in November of 2021 when rho-peg became approved, now with the trade name of Besremi from the producers Pharmacentia in the US and AOP Orphan in Europe. This agent, like the interferons, has potential side effects, as all medicines do. Very specifically, it can cause flu-like symptoms, it can cause cytopenias, increased liver function tests, rare autoimmune diseases, or depression. Do you think that the issue of dose is important? We typically start people at a low dose and monitor for these things. Overall, I find that the majority of patients tolerate interferons well, but not 100%. You need to be mindful with these therapies. Now, how one begins on this therapy, it's a dose titration. If not already on hydroxyurea, they begin on 100 micrograms every 2 weeks of rho-peg up to a max of 500. I would say most patients are probably going to end up somewhere here in the middle. And if you're transitioning from hydroxyurea, you start them a little bit lower, tapering the hydrea. And again, you might get up into this range, but in my experience, as background, the rationale is to use a hepcidin mimetic to recreate the phenomenon of anemia of chronic disease to control erythrocytosis in polycythemia vera, with its potential advantage being to decrease the red cells without cell destruction and also without the need for iron deficiency. Indeed, phlebotomy works by creating a state of iron deficiency that may aggravate symptoms of the disease, such as fatigue, restless leg syndrome, or other difficulties, shortness of breath. There's a trial done that was presented by my colleague, Dr. Ron Hoffman, the REVIVE trial, where again, there was a clinically effective dose-finding phase, and then an evaluation phase, a randomized withdrawal phase, and an open label extension phase. What you see here nicely is that with, on the left, individuals only receiving phlebotomy, or on the right, phlebotomy and cytoreductive therapy, you see good control of the hematocrit with the use of rusfertide. Indeed, during the first 28 weeks of treatment, 84% of patients did not require phlebotomy, and they were phlebotomy requiring entering the study. So it made really a very significant difference. Not unexpectedly, the agent was very specific for the red cells. So it did not significantly change the white cells or the platelets. This is not a therapy that necessarily is going to replace interferon for high-risk disease with elevation all three counts. This is a drug that may help to better control hematocrit in individuals that are only requiring phlebotomies in lower risk disease. It may be a therapy that may be helpful to add on in addition to cytoreductive therapy for individuals that are already on cytoreduction. As was hoped, there is an improvement in iron stores and improvement in MPN or PV-related symptoms that may be worsened by a phlebotomy or iron deficiency. So you see here improvement in concentration. Side effects, again, all things have side effects, and you see here, again, there may be some injection site reaction. That was by far the most common. There have been no grade 3 related effects related to the drug. And again, here you see a range of GI, headache, some pruritus, and other difficulties. This is currently, there's an enrolling double-blind placebo-controlled study called Verify. For these individuals, they're on their ongoing therapy and either plus rusfertide or placebo. So patients, again, they're all getting therapy that they would have gotten anyway and trying to demonstrate the incremental benefit. So a good study, patients are not being denied the therapy that they would have received. Certainly would have you consider this if you have appropriate patients. Now let's pivot toward myelofibrosis. Myelofibrosis is the most severe of the MPNs, the most likely to cause premature mortality and morbidity. So it is natural that many agents have begun their testing in myelofibrosis before evolving to eventually be in polycythemia vera or essential thrombocythemia. I've used the story a couple of times this year. It's now been about 30 years since I saw my first myelofibrosis patient as a first-year medical student at Mayo Clinic in Rochester, Minnesota. And that patient, it was very tragic. She was a young woman. She was from Venezuela. She was in her early 30s. She had a massive spleen. She had a splenectomy because we didn't really have much else to do to help the disease in those days. She died of splenectomy-related complications only a few days after I first saw her, working alongside my mentor at the time, Dr. Ayulu Teferi. That got me very interested in these diseases, trying to understand why such a significant burden. We were involved in many clinical trials, and in the first 15 years of my career, we really did not make a lot of progress. We were trying to beg, borrow, and steal drugs from other indications, usually without a lot of success. It was in 2005 that the discovery of the JAK2 V617F mutation was a watershed moment, both in, I think, recruiting additional scientists to study the disease and try to expand our knowledge, but also to energize partners in the pharmaceutical industry to find, now that there were potentially druggable targets, ways to specifically try to help MPN patients. Since that time, we have now seen the approval of 3 drugs in myelofibrosis. and several others on the cusp of approval. Ruxolitinib, fedratinib, and now pacritinib, most recently approved. And closest on the horizon, momelotinib, as well as ruxolitinib combinations. There have been many agents that have come and gone that were tested and either due to toxicity or the competitiveness of the field are no longer in development. Ruxolitinib was the first of these and really became a cornerstone therapy for these diseases. It's made a huge impact. Approved in November 16 of 2011, approved on the basis of the phase 3 trial that Serge Verstavchik and I led in North America of ruxolitinib versus placebo, and the European study led by colleagues of ruxolitinib versus best alternative therapy. And this showed significant improvement in splenomegaly and symptoms, clearly and vastly superior to placebo or best alternative therapy. Now, over time, we have seen another very important observation, and that is an improvement in survival. The trials were not designed as survival studies. However, it became fairly clear relatively early on that patients lived longer. They lived better, but they also lived longer. And that the length of life seemed to not be easily explained solely by improvement in debilitation, greater levels of energy, all of which were things that they had. They had decreases in splenomegaly, but we didn't really think that the decrease in the mechanical effect of the spleen really was mechanistically the reason for improvement in survival. These are nice data that were gathered by our colleagues at MD Anderson that showed not only a decade improvement in survival, but really tying it with the exposure to ruxolitinib. Why is this the case? I think it's multifactorial. I think there may be less inflammation. I think there may be a less toxic bone marrow microenvironment, less likelihood of progression toward acute leukemia. There's not a plateau, so it does not cure the disease, but the impact is real. Indeed, I saw in January of this year a patient that had gone on the COMFORT study back in 2009, and now coming to see me in 2022. I went back and calculated, well, what would have been the individual's prognosis if we had looked back in 2009? And their estimated survival by the DIPSS at that point was under 3 years. And here it was almost 13 years. Still on ruxolitinib. Now, the patient was coming off of ruxolitinib. They were now having some evidence of progression, and we put them on a clinical trial. But their survival was 4 times longer than it would have been otherwise. So a very significant advance, but still room for us to grow. Now, a couple important lessons we have learned over time. One, the dose of ruxolitinib you use matters. There's probably too much underdosing of ruxolitinib in the United States. You have to use a sufficient dose if you're going to have an expectation of improvement in survival. Ideally, 15 milligrams twice a day or more. Fedratinib, now approved since August of 2019. This is also a JAK2 inhibitor, such as ruxolitinib. It's a FLT3 inhibitor. It was approved on the basis of 2 trials, the Jakarta study, which was the upfront study compared to placebo, and the Jakarta 2 study, a second-line study that I led along with Professor Harrison from the UK. The Jakarta study with 2 different doses of fedratinib, the 400 milligrams now being the FDA-approved dose versus placebo with the potential of crossover, with improvement of splenomegaly or symptoms as the goal endpoints. What was seen was clearly fedratinib was vastly superior to placebo alone. The 400 milligram dose was chosen because it was the best combination of efficacy, and it was a better tolerated dose than 500. 500, you might get a little bit more of efficacy, but you gain a lot more in terms of side effects. So what side effects? One, there are common and then there are rare. It can cause cytopenias, as as can ruxolitinib. On the rare side, there was a small number of individuals that developed a neurologic event that appeared to be like Wernicke's encephalopathy. Over time, thiamine levels were found to decrease in these individuals. It's unclear whether those initial individuals really had Wernicke's encephalopathy. But on an abundance of caution, the FDA had put the drug on a hold and now approved, but with a black box warning, monitoring for Wernicke's replacement of thiamine. Much more common side effects, it can cause some GI side effects. This is a bit incremental compared to ruxolitinib, and typically do begin patients with either antidiarrheals or anti-nausea drugs to avoid or to control these side effects. So if I'm using fedratinib in the front line or in the second line setting, I'll start at 400 milligrams a day, assess thiamine levels in alignment with the FDA black box guidance, replace thiamine if it's low. I'll start them on fedratinib, give them PRN, nausea, or antidiarrheal medicines. I'll be honest, in my practice, I still typically give them thiamine. Thiamine's cheap, really aren't a lot of downside. I give them 100 milligrams. You get 100 pills at CVS for like $9. Not a lot of downside. And then we monitor response, monitor for GI toxicity. Usually those GI concomitant meds can be discontinued, and we'll continue them on thiamine. There were updated data regarding the FREEDOM study. The FREEDOM study is an additional kind of post-approval study in fedratinib, monitoring thiamine, giving thiamine, and both that with the GI prophylaxis, patients are able to tolerate the drug, they're staying on the drug, and we're not seeing any episodes of Wernicke's encephalopathy in patients appropriately treated. Jakarta 2 was the second line study that again showed benefit in individuals that had failed ruxolitinib. These were updated data that I presented in a series of meetings over 2020 and 2021, and is a helpful backup option. In 2022, if a patient has failed ruxolitinib, fedratinib should be your preferred option as second-line therapy for an individual with a platelet count of over 50,000, especially if they do not have access to a clinical trial. Pacritinib, approved the most recent at February 28th of 2022. Now, this drug is a little bit different spectrum of action and a little bit different set of patients. These are more these cytopenic patients with myelofibrosis, lower counts. They tend to more often have primary myelofibrosis. They tend to be JAK2 negative. They have a higher risk of acute leukemia. This is a JAK inhibitor, but it's also an IRAK1 inhibitor that may change its spectrum of activity and may allow it to be more successful in this subgroup of patients. In studies, it has been seen. These were the PERSIST-2 study for patients with a platelet count of under 100,000, showing improvement at 200 milligrams twice a day compared to either ruxolitinib or once a day for control of splenomegaly and of symptoms. And indeed, the 200 milligrams twice a day is the recommended dose. As one would expect, the platelet count was stable for these individuals to improving. Again, it's not a platelet therapy. What this allows is the ability to use this medicine in individuals with a platelet, irrespective of platelet count, but that it is safe for individuals with a platelet count of under 50,000. And as such, it is unique amongst NPM therapies and having been tested in this group of patients and found to be safe. There also can be improvements in anemia. And again, here data from my good friend and colleague, John Mascarenhas, showing improvement in rates of transfusions. Side effects, again, GI-related side effects, so it overlaps a bit with fedratinib in that setting, as well as can cause cytopenias. This too now is approved, here showing the FDA label with its trade name of Vonjo, 200 milligrams twice a day, with or without food. It is for platelets, individuals with myelofibrosis with a platelet count of under 50,000, whether that be frontline or second line. Now, there are not many patients that are frontline that have a platelet count of under 50,000, but if so, surely consider this. The fourth JAK inhibitor is on the cusp. It is seeking approval, and I had the honor of presenting the data from the phase 3 study just again at the ASCO meeting just about a week ago of this phase 3 study, momelotinib versus danazol in symptomatic and anemic myelofibrosis in patients that previously treated with a JAK inhibitor. Here, this JAK inhibitor also inhibits ACVR1. So this is the flip side to the hepcidin story. You heard earlier we were trying to mimic hepcidin to control erythrocytosis in P. vera. Here we try to decrease hepcidin through the inhibition of ACVR1 to try to improve anemia, improve erythropoiesis. There have been previous important studies with momelotinib. This JAK1 and JAK2 inhibitor, in addition to ACVR1, in the Simplify-1 study, which was the largest randomized study compared to ruxolitinib, it showed non-inferiority for control of splenomegaly. It showed rates of transfusion requirement. Momelotinib was superior to ruxolitinib. In improvement in symptoms, we saw about a roughly 30% improvement in myelofibrosis symptoms, both in Simplify-1, that upfront study, and Simplify-2 in the second-line setting. It was slightly inferior to ruxolitinib as related to symptoms, but better with anemia. There was still felt to be a strong data gap in the second-line setting to round out the registration profile for momelotinib, which was critical, so we designed the momentum study. Here, these were individuals that were symptomatic. They were anemic. They had previously been treated with a JAK inhibitor. So 195 patients were randomized in a 2-to-1 fashion, momelotinib plus placebo versus danazol plus placebo, with a momelotinib open label crossover with endpoints of total symptom score response and secondary endpoints of transfusion independence and splenic response. This study hit all of its endpoints. First, a clear improvement in symptoms, which was a primary endpoint compared to danazol. Second, a clear superiority for improvement in splenomegaly, whether one uses a cutoff of 35% or 25% volume reduction. This is the second-line setting. Indeed, we've shown in the past that a greater than 10% volume reduction in splenomegaly was associated with improvement in survival. For transfusion independence, the goal had been non-inferiority, but was really close to showing overt superiority over this active control arm. Rates of transfusion independence rose from 13 to 31% on momelotinib versus 15 to 20% on danazol. And you see here on the right, the really superiority of momelotinib, and then the kind of correction of the danazol arm up to momelotinib levels after crossover. In terms of toxicity, GI and some low-grade cytopenias. Again, so you're getting a sense many of these new agents do have some overlap in terms of toxicity. GI and watching the counts tends to be a recurring theme. The study was not designed as a survival study, partly because of the period of observation, the need for crossover. That being said, there certainly is a strong trend toward improvement in survival of momelotinib versus danazol. And this is despite the fact that there was a bit of an imbalance of death due to COVID. So this study completely accrued during the time of COVID. It started accrual in April of 2020, and particularly during 2020 pre-vaccination, there were 6 deaths on the momelotinib arm and 1 on the danazol arm. We certainly have not seen after things have kind of normalized in the COVID world, that there has been any significant issues. So a lot of issues pre-vaccination, certainly JAK inhibitors and COVID have been found to have some interaction, particularly in the pre-vaccine setting. There is some data that danazol may actually have some protective effect against COVID. These data build on some of our prior observations that there may be a survival advantage, and that survival advantage may be tied to an achievement in transfusion independence. Indeed, from the simplified studies, this was an analysis that previously presented that's being considered for publication as we speak, or it's in press as we speak. You see here the difference in survival. So how do the JAK inhibitors fit together? Well, one, if we think about the spectrum of myelofibrosis patients requiring therapy greater than symptomatic low risk, if you have proliferative frontline, ruxolitinib is still our cornerstone in hopefully an appropriately dosed fashion. Second line, proliferative, fedratinib. If you have cytopenic myelofibrosis, pacritinib is your frontline option, particularly if the platelets are under 50,000. I think if momelotinib becomes approved, I think there will be some delineation between patients where anemia is the main driver and a consideration will be momelotinib, or whether thrombocytopenia is the main driver and it'll be pacritinib. Now, excitingly, there are new JAK inhibitor, non-JAK inhibitor mechanisms of action. The last patient I saw today, and indeed I saw and raced home to give this talk for you all, was to put a patient on a non-JAK inhibitor mechanism of action clinical trial. And these are exciting to see these rolling out. Indeed, there is an unprecedented number of alternative targets being looked at, usually with or without JAK inhibition, as kind of a cornerstone. Cell cycle checkpoint, anti-fibrosing agents, other signaling tyrosine kinase inhibitors, agents looking at the apoptotic pathway as they've been successful in MDS and AML, other immunomodulatory drugs, or a range of things that are epigenetic modifiers. So let me start with the first. This is in the MANIFEST study. This is with the BET inhibitor pelabresib. This has created quite a bit of excitement. And these slides were just presented just again a few days ago by my colleague Claire Harrison in Vienna, for those that had the opportunity to attend. Again, it has been felt since the beginning of the rollout of this agent that the combination of both BET inhibition and JAK inhibition may be beneficial, and that there's a synergistic effect in the combination of these two agents. The MANIFEST study was a study designed when the agent was with Constellation. The agent is now with the company Morphosis, but with multiple arms that can to evaluate a variety of scenarios, either alone as monotherapy, in combination, is either frontline or as an add-on or as a second line. So multiple different approaches, of which the one that I think has gotten the most excitement and really captured the imagination is the thought of two drugs from the get-go in JAK inhibitor naive patients to optimize response. And these are the data that Professor Harrison shared with us in Vienna, which showed very significant responses in terms of splenomegaly and in terms of symptoms. Indeed, you see here in this waterfall plot that the vast majority of patients had significant reduction in splenomegaly, and that SVR35 at any time was 80% of the patients, with 69% maintaining it at the time of data cutoff. And likewise, the median total symptom score change was an improvement of 60%. So these are really some of the very best data we've seen to date for a combination approach for therapy for myelofibrosis. Here you saw, again, individuals that had a suboptimal response to ruxolitinib. When you add in the other agent, again, achieving good response in arm 2. You see here in arm 3, the combination leading to durable improvement in that spleen volume, both in the frontline setting on the left and in the add-on strategy on the right. These data do tend to suggest that there may be advantages to using the combination upfront versus waiting for an add-on approach. Side effects, again, there's a theme here, cytopenias and GI. So these, again and again, do seem to be a recurring theme in terms of side effect with new medicines in MPNs and need for management. Again, as one looks here, arm 2, very similar in terms of the spectrum of toxicities. Interestingly, there were a series of correlative studies that were also presented that showed the potential of some improvement in fibrosis for these individuals, and they are currently using new digital pathology mechanisms to further interrogate these data. And there was also some correlation of improvements with some other digital pathology measurements as related to fibrosis, as well as other histologic changes that could be assessed through digital pathology. All of this has led to the MANIFEST-2 study, which is actively accruing as we speak. Certainly would strongly consider anyone that's watching this, if you have a patient that is a candidate for JAK inhibition, newly diagnosed with myelofibrosis, consider the MANIFEST study before they begin on JAK inhibition. So this is for JAK inhibitor naive patients. Rux versus Rux plus pelabresib. The second agent, and there's many, but I'm just highlighting a couple, is navitoclax. This is a cousin of venetoclax. This works against BCL-XL. Indeed, it's been known for a while that there can be apoptotic resistance in myelofibrosis. Indeed, a million years ago, this was the subject of my NCIK award when I was in the lab of Dr. Scott Kaufman. And indeed, it's gratifying to see this kind of come full circle with a therapy targeting BCL-XL. Francesco Passamonte presented some updated data. Like the MANIFEST study, there were multiple cohorts, and they presented at EHA the cohort of individuals that were JAK inhibitor naive. And here very specifically, both JAK and BET inhibitor treatment naive, to not confuse matters. And they were started on navitoclax plus ruxolitinib with, again, improvements in splenomegaly and symptoms. In terms of toxicity, and there were a range of low-grade toxicities, but overall the investigators felt the drug was well tolerated. Potential of cytopenias and GI side effects, again, should not be a surprise. Thrombocytopenia perhaps being a bit more represented. Here you see reduction in splenic volume, and again with 63% of individuals achieving a spleen volume reduction under 35%. On the right, you see the durability of those response. And then you see here about a 41% improvement in symptoms. And again, this is in a single arm phase 2 study. So the numbers are small. And it's also very difficult, I'd say, to compare these data versus the data I showed you again from the single arm phase 2 of MANIFEST. I do think the phase 3 study are going to be looked at very carefully. They're not going to be randomized between each other, but I think with those numbers and power, we may get a better sense of, how do these things look like side by side. Some improvement in fibrosis. And again, I think the evolving mechanisms with digital pathology will be helpful in sorting out these data. We're at an unprecedented time with the greatest number of phase 3 trials ongoing in myelofibrosis, truly ever, in a recognition of advances in the disease. So one, there are drugs where we're looking at truly for individuals that have failed JAK inhibition. There's currently a telomerase inhibitor trial with imetelstat that is ongoing as a second-line therapy with survival as the primary endpoint. There are the add-on studies. Luspatercept to help to improve anemia, that's ongoing and accruing. Would recommend you consider that for that TGF-beta ligand trap and help to improve anemia along with ruxolitinib. Navitoclax, which I mentioned, parsaclisib, PI3 kinase inhibitor from Incyte that's active and may help to add to the benefit of JAK inhibition, and the MDM2 inhibitor from Kartos. There are the combination studies in JAK inhibitor naive patients. Pelabresib, which I mentioned, Manifest-2, Navitoclax combination, and the PI3 kinase inhibitor. So again, a robust pipeline of studies. Again, if you have patients with myelofibrosis, certainly be considering, if things aren't going ideally, should we consider a clinical trial? And if they're JAK inhibitor naive, consider one of these, because they're going to get ruxolitinib as the control arm or in combination in these, and we hope that these are incrementally better. So how do we help put all this together before we pivot to some time for some Q&A? Well, first, in patients where transplant is not selected, I think in low-risk individuals, we're going to be thinking about, one, if they're not symptomatic, observation or pegylated interferon. If they are symptomatic, ruxolitinib or a clinical trial. Again, with all those JAK inhibitors, only ruxolitinib has really been used in lower-risk disease. In individuals that have a platelet count under 75,000 in intermediate to high risk, pacritinib. If they're anemic, momelotinib, or perhaps a combination, ruxolitinib plus luspatercept, ruxolitinib plus pelabresib. Or if they have standard myelofibrosis, normal counts, probably still ruxolitinib or fedratinib. There will be a subset at a minimum that I think we will identify. Benefit from combination therapy upfront, rux and pelabresib or navitoclax or parsaclisib or another. I do think the data from the phase 3 will be important to identify. Is that everyone? Is that a subset? Patients with a platelet count less than 50,000, pacritinib. Second line, if the spleen is a major issue and the counts are okay, fedratinib. Anemic, momelotinib, or again, a combo. An increased risk, again, I think it'll go back to those combination approaches. Accelerated or blast phase, this is a tough group of patients. Some sort of enhanced induction. 7 and 3 doesn't really cut it in these patients, not very well. So if there's a target, use a target, consider a trial. No transplant, Rux plus a targeted therapy, if there's a target, is both the ongoing efforts in clinical trials and hopefully beneficial. If you fail frontline therapy, I don't think there's really a lot of rationale for second-line therapy in this group of individuals off study. I think a trial or support the survival in secondary AML from MF is very poor. And if there's not really a transplant in sight, I would be very judicious about therapy. How do we bring this to really precise and personalized cancer care? Well, I think we've learned a lot more about the clone, but there's a lot more to having a disease like this than just the clone. It's got to live in a person who has all these other issues, their risks, their comorbidities, their other medications. How do we weave together all of the factors to try to come up with the best treatment plan for really what is a chronic disease that we're trying to make a great impact upon and work in a shared decision-making model with our patients? With that, I very much would like to thank many individuals, clearly the tremendous MPN community. One of the things that's been very rewarding about being in this community, tremendous patient engagement, wonderful investigators, people very generous of their time and eager to collaborate. It truly is a wonderful space to be involved in, and some wonderful organizations that really have helped to make tremendous support: the MPN Research Foundation, the Chemo Lymphoma Society, MPN Advocacy Education International, the MPN Education Foundation, and many others. And certainly many wonderful friends and collaborators. Working in teams is one of the exciting things we all get to enjoy as being in academic medicine. And with that, again, my thanks for the invitation. I'm glad to take any questions that you have. Thank you.
Thank you so much. That was a wonderful, thorough lecture. I can't wait to listen back to it later on, but I'm going to pass the mic over to Pratusha on the Clubhouse side because she's going to help moderate the Q&A.
Thank you so much, Lauren. Thank you, Dr. Mesa, for that amazing lecture. My name is Pratusha, and I'm the moderator over here at Clubhouse. We have a lot of questions ready for you, and we are really excited to get started with our Q&A portion. So just as a reminder to the audience member, feel free to submit questions to our moderators via the back channel, and we will get them in the queue. So for the first question, I'm going to pass the mic back to Lauren.
Okay. And can you hear Pratusha okay over on the Clubhouse side, Dr. Mesa?
Yes.
I kind of, but if I miss anything, maybe Lauren, you can just repeat the question for me.
Absolutely. So I'll start off. I really liked that one of the central missions of the Mesa Cancer Center is advancing the science of cancer for Latinx patients. Have you had a lot of success with enrolling Latinx patients into trials? We know that diversity in trials is really important. What are some of the obstacles you faced?
It's a good question. So at our center, we enroll almost 60% Latino patients on the cancer clinical trials. It's a key part of our mission. It's a key group in our community. We work with other wonderful centers like Virginia Commonwealth and others that really excel in wonderful accruals for African American patients, or University of New Mexico with Native American patients, or Pacific Islanders with the University of Hawaii. We know that there's a lot of challenges. There can be around trust. It can be around health literacy, access, and sometimes the implicit bias that investigators may feel that someone who comes from a diverse background or has social challenges in the social determinants of health wouldn't be interested in a trial. And we found that really that's not the case. We find there can be barriers, and we work to try to overcome the barriers. We do find in our South Texas patients, one of the critical things is really to be mindful of language and culture. So one, if English is not the primary language, can you really both convey, both in terms of consent, but also in terms of education around the disease, truly what the issues are and where the role of a clinical trial fits. We've also found that trying to really tap into the family health expert as a critical part of both educating around the disease as well as discussing the role of a clinical trial is critical. So that health expert might be a pharmacy tech, it might be a respiratory therapist, it might be a physician. But if that individual is not involved really in the discussion, the patient frequently, feels very uncomfortable or won't participate or doesn't truly get kind of the goals of therapy. So some important lessons learned, but I think a critical thing is that it is wrong and sometimes an implicit bias that individuals that do have these challenges don't want to participate. They're just sometimes challenges we need to overcome.
Great answer. Pratusha?
Thank you so much, Dr. Mesa, for that amazing answer. I will be asking the next question. So aside from JAK-STAT pathway inhibition, do you foresee any other pathways that can be used as potential targets for treatment? And a follow-up question is, among the therapeutic agents that we presented here and looking at their pharmacokinetics and dynamic profile, which do you think currently would be the most promising agent for treatment? Thank you.
So I think fortunately we have multiple, at the current time, and most of them play a role really as being synergistic with JAK inhibition. So they're not alone, but really it's the combination. So I think BCL-XL, I think BET inhibition, PI3 kinase, HDM2, telomerase inhibition, all of those I think have great promise. At the current time, the strongest data, or at least the most mature data, I'd say, is with BET inhibition and PI3 kinase inhibition. But, a lot of good phase 3s out there, so good data to be seen. And I really hope, they're all beneficial. People say, well, myelofibrosis is not a common disease. How many drugs can the disease support? The good news is that many of these agents will end up having a range of different benefits in other myeloid disorders, in MPN and MDS overlap syndromes, in acute leukemia. So, I'm a firm believer, the more the merrier. These patients are heterogeneous. The more options we have, the better we'll be able to treat patients.
Thank you so much, Dr. Mesa. And I will be passing the mic to Gayatri for the next question.
Hello, Doctor. Thank you so much for that very informative talk. I really learned a lot. Doctor, I had 2 questions actually. So my first question is, what are your thoughts on the use of anti-CD47 antibodies for the treatment of polycythemic vera and myelofibrosis? And my next question is, considering the recent increase in maternal age and the occurrence of myeloproliferative neoplasms in pregnant women, what are the standard treatments that can be considered? Do you think we can use pegylated interferon alpha as a frontline treatment in these patients?
Good question. So kind of two ends of the spectrum. So one, the CD47 certainly has been very interesting. The drug, and certainly my good friend Ravi helping to lead those efforts at Stanford, active in AML and certainly be active, I think, in that setting. I think in earlier MPNs, I don't think we have much data yet, but I'll be interested to see how those data evolve. I do think interferon for earlier disease, I think, will become more standard of care. And these are one of the few options that we've been able to safely use during pregnancy. So having managed many women through their pregnancy with PV and ET in particular that needed cytoreduction, both during conception and pregnancy, pegylated interferon has really made a big impact. Because there are other cytoreductive therapies of anagrelide, hydroxyurea, and even ruxolitinib are truly not appropriate and maybe even teratogenic. So it really has made an important impact. And the good news is that, with good medical management and good involvement of high-risk obstetrics, there have been many women that have been able to successfully conceive, carry to term, and deliver healthy children.
Thank you so much, Dr. Mesa, for that wonderful answer. And I will be passing the mic to Billy for our next question.
Hi. Thank you so much. This was a really amazing talk. I just wanted to ask, for the sake of the audience, can you explain a little bit what's the difference between a front and secondary line treatment?
In which condition?
He wants, I'll repeat it he wanted to know for the patients listening, can you explain the difference between like a first and secondary line treatment?
Of course. So frontline therapy, that's typically when we consider when we need to start a medicine, what is the medicine we start first? So there are times we will start in some of these conditions without a medicine. In ET, sometimes we'll begin with observation alone, or we'll use aspirin. And then when we talk about frontline, it's the first medicine we use that tries to lower the counts. The same would be true in polycythemia vera. Second line will be, what would we use if the first medicine we used was not successful? And we define not successful by a range of ways, depending upon the situation. But it could be either that it didn't achieve what we wanted it to achieve, or that the side effects were unsuccessful.
Great answer. Thank you so much.
Thank you so much, Dr. Mesa. And I will be passing the mic to Billy once again for our final question.
Yeah, thank you so much. That was really, really insightful. The last question I wanted to ask was sort of more towards our younger attendees just getting into medicine. What inspired you to pursue medicine and eventually go into oncology? And has it lived up to your expectations?
So I would say it definitely has lived up to my expectations. What's exciting about academic medicine is it is really the perfect combination of a field where you really get to interact with others. You feel like you're a member of a team. You feel like you're making a difference with patients, but you're doing so in a way where you're also trying to bring in cutting edge science. And I think that's really why the broader cancer space is so exciting. You know, it's an era of tremendous innovation, of tremendous scientific advance, you know, where things are moving every day. If we think back to the tremendous progress that occurred during the time of COVID, many of those were on the basis of critical things that had evolved because of research in cancer. The rapid advances in diagnostics led to rapid developing of the PCR testing. The mRNA vaccines were based off of cancer treatment formed vaccines that formed really the basis for that. So it's an exciting time. It's an exciting time to be in medicine. I think we clearly have seen the tremendous impact you have, kind of regardless of which field you have. You know, what makes academic medicine fun is that it's also very diverse. You get to teach, you get to be a researcher, you get to care for patients, you get to travel and meet colleagues and plan the future of medicine. It's fun, it's exciting, it's rewarding, and excited that you guys are on, and hope that this has been a helpful discussion.
Thank you, it really has.
Thank you so much, Dr. Mesa. What an amazing way to end our Q&A session and our keynote. I wish we could go on, however, we are reaching the end. Thank you for that wonderful talk. And on behalf of everyone at Clubhouse, we are incredibly grateful to have you here on MedNews Week. I cannot wait to rewatch this session along with the others. Thank you to all of our panel members and our attendees from all different platforms for your participation and questions. If you missed this lecture, fret not, you can replay here on Clubhouse or even on our YouTube channel as well. Lauren, do you have any last thoughts?
Thank you so much for being here. We loved having you. I know a lot of people will be replaying this, as will I. So thank you again. I really appreciate it.
Thank you. Thank you for the honor of being here.
Thanks, Bertusha.
Thank you, Lauren, and thank you.
Okay, I'm just going to cut the live.